Hello, everyone. Good morning, good afternoon, good evening. Let's, like on previous webinars, give just a few seconds for everyone to log in, and then we'll start. Okay. Hello and welcome to the Nursing and Midwifery in Crisis webinar, part of a series of webinars that result of a collaboration between Nursing Now Challenge, JPIGO, and Jai Mental Health. My name is Romer Salvil. I'm a mental health nurse and the founder of Jai Mental Health, and I'm also a Nursing Now Challenges champion, and I'm really pleased to welcome you to today's webinar. This is actually the fourth of a series of chats that we've been having over the past few months that, on one hand, examine the role of nurses and midwives in crisis situations all over the world, and on the other hand, encourage a discussion on what kind of support is available to nurses and midwives, with a particular focus on mental health and well-being. In today's webinar, we will be examining the roles of nurses and midwives in health crises, and a really pertinent topic because we've been, as everybody knows, experiencing a global health crisis for the past 2 years, a crisis that isn't yet over. We have a mixture of health professionals joining us today in the panel and who will share their experiences with all of us. Our keynote speaker is Vanessa Kramer, Health Emergencies Program from WHO. We will then hear from the experiences of nurses and midwives in different parts of the world. We've got Vuzi Ndaba, who is a Senior Field Project Officer for Voluntary Medical Male Circumcision, HIV Prevention and COVID Response, JPIGO, South Africa. We'll hear from Gila Zarbiv, who's a registered midwife from Israel, and she'll tell us about COVID response program that she's been participating in Israel. And we'll also hear from Jennifer Breeds from JPIGO in America to talk about sexual and gender-based violence. We'll also be joined by Pandora Hartman, Chief Nursing and Midwifery JPIGO, who will join us in the panel discussion, which usually takes place after each individual panelist shares his or her experiences with us. Today, we're going to do this a little bit different to what we've done on previous webinars. And we want to start by telling you about a wonderful opportunity that we've mentioned on previous webinars, but we'll mention it again today. Thanks to funding received by the Burdett Trust for Nursing, the Nursing Now Challenge is able to offer you the opportunity to take part in a free health action training course. And Pat Deeney, who is the CEO of Health Action Training and who has joined us on previous webinars, is here to tell you more about it. So Pat, over to you.
Okay, thank you, Joe, and good morning, good evening, and good afternoon to everyone. My name is Pat Deeney, and I'm the CEO of Health Action Training, which is a training company that is providing a series of courses and programs of training as part of the Nursing Now Challenge. And as Joe said, these are free to you. There's a range of courses, both 12-hour, 36-hour, and even train the trainer courses and so forth. But before I move into that, I was just going to make a few comments about my background. I myself am a nurse educator, have been for about over 30 years, and most of that time has been spent in preparing nurses and doctors as well, and sometimes journalists, for work in crisis situations or disaster situations across the world. I myself grew up in Northern Ireland. At that time, it was a conflict zone, and in some sense, it's still there to some degree, but we've had 20 years of peace and stability now, which is fantastic. I also worked in Iraq during the mid-80s and in former Yugoslavia, which all experienced war and crisis and so forth. But this, as Joe was pointed out, this crisis is actually on a grander scale than probably anything we've ever dealt with before, and requires a lot of resilience on your part, or coping and recovery. So if it's okay, I'll just share some slides here with you. Okay, just take a minute to come up. For me, it's important actually to emphasize this idea of actually knowing when a community has capacity or when a community is vulnerable. And that is actually the central tenet of all theoretical underpinning of how communities respond to crises and disasters. And you can see, actually, if you look at this more closely, you can see here in the red, you can see that awareness and education, good communication, frequent exercising, role play and simulation, actually practicing how to respond is absolutely a great way to facilitate capacity. Because actually, if you look to the other side, you can see that when poor communication, particularly between healthcare teams and within healthcare teams and between healthcare teams and communities, falls apart, this, in a sense, adds to the vulnerability of that community to actually cope with the crisis and recover from the crisis. The International Council of Nurses, as most of you may be aware, actually have identified 3 levels and 8 domains of actually competency related to coping with crisis and responding in disasters. And we focus on domain 1, which is preparation and planning, and also in domain 2, which is communication. And these 2 domains actually are seen as being necessary for you to actually step forward as taking a leadership position, either in your own community or in your own team, or be that multidisciplinary or multi-professional. Health action training, what we do is we use ideas from actor training and applied drama methods to teach health professionals how to understand attention and intentional behavior, be able to perform compassionate and more person-centered care, even in crisis situations. But it's actually, it's all about managing team relationships and communicating effectively. And central to all of this, as was mentioned earlier, we know that looking after yourself and your own resilience and being able to actually sort of care for yourself and recover is absolutely critical. So that's a major part of our programs. The one that actually I'm really pushing today is this idea of the 12-hour course, which will be offered in 4 3-hour slots, and it's called Coping with Crisis, Wellbeing and Growth. It will be offered via Zoom at times that actually suit your time zones, and it really deals with things like readiness and confidence in dealing with crisis. Finding your voice is absolutely very important, because nurses in particular need support and sometimes encouragement to actually speak out in relation to the needs of their community and the needs of their own team. Self-care, well-being, and this idea of post-traumatic growth is very important. So what we usually ask people, it's a common metaphor, is in resilience, we often think of the tennis ball can bounce back very quickly, but really the tomato is easily crushed, but actually promotes a lot of growth out of the many seeds that fall out after a tomato was crushed. So these metaphors are absolutely used then in role play and simulation, and giving you an opportunity to actually practice finding your own voice in many ways about this particular topic and helping yourself to heal. The longer course, actually, 12 3-hour sessions, is more extensive training, particularly in person-centered practice, and called sympathetic presence, which is an element, one of the central processes of the person-centered framework. But it's really about creating a person-centered culture in your organization and being able to lead in crisis. And again, emphasizing relationship understanding and dealing with different audiences. And that is sort of modified to suit the particular culture that we're working on. If you do this 12-hour course, the 12 3-hour courses, you're able to progress on to train the trainer courses are then offered to you if you want to become a health action trainer in your region or organization. Our long-term intention is to set up international hubs, across the world, and for there'll be groups of health action trainers working collaboratively with local drama practitioners to actually develop, culture-specific courses for the particular region. And you will continue to be supported as part of the health action training network that we will develop. I have some references here for you that you might want to consider. A copy of this will be sent out by Nursing Now. I apologize, I will not be there at the end for the panel discussion, but I know that my colleagues in Nursing Now Challenge will be able to deal with any question that you have, and please do write your questions in the chat box or contact Nursing Now for further information. So thank you very much.
Pat, thank you very much for that. Thank you, first of all, for introducing yourself properly, which, I made a lousy, quick introduction. So thank you for telling us about yourself and your background more, and also for giving examples of some of the courses that are available to people. I mean, I have to say, I love the analogy of the crushed tomato that you were talking about, and the seeds and the growth. I'm going to steal that for lots of things.
Yeah, it's very good. It's not mine. It's not mine job, but
it's really good though. It's really
it's a super metaphor. Yeah.
Yes, really good metaphor. And so thank you for providing more details on the courses. And as you said, and I can see from the chat box that people are already kind of questioning how to access it. Some people experiencing problems with their firewalls in their computers, but I'm sure that the Nursing Now team in the background can kind of help you through these kind of obstacles and find out what's the best way of accessing these courses. So thanks a lot, Pat. Thank you very much, and look forward to seeing you soon again. So let's move on, and we're talking about health crisis today. And again, like I said at the introduction, what a crisis we've been living through the past 2.5 years or so. No corner of the world remained immune, literally, to the current pandemic. And I think this pandemic made us aware of our capacity as well as limitations to respond to these sort of challenges as health professionals, as well as a global society. And it has also brought to surface many of our vulnerabilities and highlighted ongoing healthcare inequalities at a local, regional, and a global level as well. So health crises are part of our past, they're part of our present, and without a doubt, our future. And nurses and midwives, we usually seem to be at the center of these storms, in most cases being one of the main firefighters battling against invisible but lethal opponents. And on this note, I'm really pleased to welcome Vanessa Kramen, who works for WHO, part of the Health Emergencies Program. And Vanessa, I believe you are literally on the other side of the world in New Zealand. So thank you for joining us from so far. I mean, the time difference between the UK and New Zealand is huge. So thank you very much. You're working WHO Health Emergencies Program. Tell us about your nursing journey, about this program that you're part of, and your perspective, from your perspective, what is the role that nurses and midwives have during health emergencies? So thank you for being here, Vanessa. Thank you for joining us, and over to you.
Thanks very much for the kind welcome, Joe, and lovely to see everybody and colleagues on the call. I'm just going to bring up some slides. Bear with me. So the team at Nursing Now asked me to also talk a little bit around, sorry, it helps to start from the beginning, doesn't it? You go through those. So wanted to talk a little bit around some career development, but also how I wound up working in some of the more prominent health crises. And of course, as Shoa said, COVID is the disease of the moment. So certainly happy to walk you through, and I'm looking forward to some questions at the end. Keynote's a bit overwhelming, but happy to share my experiences and some reflections a little bit on where we are today with COVID-19 pandemic. So this is how it started. I've been nursing for about 24 years. I trained in New Zealand, where I'm currently calling in from. This is not my first pandemic, I often say. So I was really lucky, and it was a real privilege to start my career in nursing and HIV care. So in the mid-90s, responding to people affected by HIV, able to work both in an inpatient setting and in the community, which was a really lucky start to my career, working both in infectious diseases, but also thinking a little bit around health inequities. So it started at a pretty nice looking hospital. And then it took me to a lot of different places around the world. So I was quite lucky. I stepped into always wanting to work in the developing world, wanting to feel like I could contribute in a different way. And I was quite careful and considerate around the skills that I acquired throughout that early phase of my nursing career to make myself feel as useful as possible to go to some of the more challenging parts of the world to hopefully bring one more set of hands to the forefront of providing care for people in times of strife, difficulty, war, conflict, disease, famine. So I've kind of had a bit of a career with several different groups. I had academic postings in Nigeria. I worked with a group around scaling up of HIV partnerships, bringing antiretroviral services and implementation to Botswana at the time of their emergency. And then I started working with Médecins Sans Frontières, and I've worked for them for about 13, nearly 14 years, both in the field, so at the forefront, also in coordination roles. And then eventually I moved myself to headquarters, where I spent 3 years managing the emergency desk, responding to emergencies in lots of different parts of the world. So it took me from places where dealing with cholera outbreaks to displacements, to natural disasters, all the way through to the Syrian crisis, to the exodus of people from Syria, people moving across the Mediterranean in boats and looking at search and rescue responses. I've worked across pretty much every infectious disease topic over the last 20 years, from cholera to Ebola. And so, yeah, COVID was a new challenge, but it took me here to WHO, which I'm in my 4th year now, and have had an interesting journey. Started with polio and wound up now working with the health emergencies team on the COVID-19. So that's a little bit about me. I'm really passionate about global health, about equity of care and services around the world. And that's, I guess, been my driving passion over the last 24 years of nursing. So I just wanted to reflect a little bit on a very poignant message from Dr. Tedros, who's the Director General at WHO, around nurses being the backbone of any health system. And I think I'm sure everyone on the call and anyone on the panel today can testify to that. I think we play such a central point in care. And I think the State of the World Nursing report was actually commissioned just prior to the pandemic and was probably being written up in those last phases and published early in the pandemic. And I think we couldn't ask for more of a timely document, really, to echo the need to look at nursing, support nurses, look at all of the challenges in which we face, and for midwives around the world, to continue to do the work that we do, to be at the forefront of science and medicine, and at the same point being anchored in advocacy and care and working across the dimensions, from whether it be from the community to inpatient services and everything in between. So just a great document. If you haven't looked at it, it's really worth a read. And I really encourage everyone to kind of know a little bit about our nursing history, where we are in terms of the state of action around the world, and also to understand a little bit the plight of nurses in lots of other countries. If we think about the onset of the pandemic, and I think what it's brought for us as a group of health professionals, having to respond, to shift, to adapt. And I think I was looking at these pictures and constantly amazed to see nurses all over the world having to find a way to thrive in really uncertain circumstances and adapting to that. And I think that talks to our resilience as a profession, and the prospect of us to be able to continue to adapt and adjust to whatever comes our way. Not the first pandemic, won't be the last. I wanted to reflect a little bit on just some of the key challenges which I think we've been faced as a profession and as a health workforce. You know, the COVID-19 pandemic has been dynamic and evolving, and this has forced us to have incredible amounts of real world learning. So things changing from week to month around our practice as we understand prevention and transmission, diagnostics, the arrival of the vaccines, and now we're in a really important phase of also being able to enhance treatment of COVID-19 across the spectrum of severity from mild to moderate to severe and critical. So I think, you know, that simply that evolving nature has been a true challenge globally felt. Magnitude, I think, you know, unprecedented amount of infection happening simultaneously around the world. And of course, the nature of being able to respond to that. This is not like when we're responding to an outbreak in a part or a region of the world, whether it be country or regionally affected, where we can pull resources and send them to help respond on the ground, because everyone was, for the first time in a very long time, in the same boat. I think we've struggled an awful lot in terms of access and dissemination of reliable information for nurses and midwives and health workers across the board because of the changing information. Getting that in real time so that it can inform your practice, inform your care has been a real challenge. And also the volume of information coming from lots of different directions, making it quite difficult to discern the right thing to do for the right person, for the right family in your setting. We've had to adapt enormously to new care elements. So for some of us who maybe had worked in critical care or in parts of emergency management or in infectious diseases or cancer care where PPE is a norm, or in theatres, but now seeing PPE used across the board, looking at the testing strategies, and of course absorbing all of those treatment and clinical interventions to bring them into care has been a challenge. Adapting to the way we orchestrate that care, and I think that you know, there has been so many telling moments throughout the course of the pandemic where we've had to look at how we interact with patients, we've had to look at how we interact with families and loved ones, and that changing that dimension. And I think, you know, in the sort of, you know, Herculean way that we often do, we find ways around it, but we recognise those compromises to adapt that practice. We've had to look at rapid expansion of COVID-19 services, and that's across the board from outpatient to inpatient. And of course, what we've seen in many parts of the world is a staggering effort to scale up vaccination services. So despite it being a challenge, I think it's also an incredible success to see countries that have been able to absorb and scale out those activities in such a short space of time. I think living with uncertainty and ambiguity, and I think that's been something that we've seen in almost every corner of the world. And I think just to make some comment on the effects of lockdowns and border closures having an enormous impact on the nursing and midwifery workforces. We are a migratory group of people. We surge in other countries. Some countries are really reliant on the influx of nurses coming from other parts of the world. And I think that's been incredibly challenging to overcome. We've also seen, of course, the epic disruption of healthcare services, and that having that roll-on effect in terms of health outcomes for patients and for communities at large. Staff health and wellbeing, and it's not fair that that's down the bottom because I think it is just something that is omnipresent, looking at the workload and high disease burden that we have seen collectively around the world and what that's meant as nurses responding to patients. Of course, attached to that, the high mortality and feeling and seeing those compromises in quality of care that we've had to have, all while living with our own individual exposures to the virus, to having to deal with our own family and home responsibilities, and many colleagues around the world dealing with that challenge of having kids at home, homeschooling, having to work, being really fatigued and dealing with that high workload in our healthcare environments, which, as we know, pre-pandemic was also highly stretched, and of course has added extra weight to that challenge. Misinformation, again, sort of strange order of this, but misinformation has played a massive challenge, I think, in the way that we can go about our work, provide care in the most meaningful ways. And it's been a real challenge. And I just dropped the link there for the epidemic website. If you haven't had a look at it, it's a really interesting sojourn for an afternoon to really look at how the information epidemic has affected populations in different parts of the world. And I just wanted to finish on that last point, which is around inequity of access to COVID-19 tools, and that's particular for the low and middle income countries around the world. We've seen some incredible efforts in some countries, and we've really seen slow pace in others, not because they didn't want, but because they didn't have the tools to do the job. We're really starting to see that, I think, correct now, really positive signs for vaccination access in the coming 6 months, and that is great, but it is really slow. So we have not seen that equity around the world that we would have liked to see. Of course, you can't talk about the challenges without sort of some recognition of just the amazing things that have occurred throughout the pandemic. And I just wanted to signpost a few of them. We have seen unparalleled scientific research and development. I think the speed in which colleagues in the research world have moved at pace has been phenomenal. And we are, profiteering from that every day. As I said before, that the vaccination efforts around the world to scale, even in some of the most challenging parts of the world. And having worked in polio vaccination previous to my work on COVID, I know many of the polio teams in many parts of the world have absorbed that responsibility of moving COVID vaccination around the world. So, massive effort whilst maintaining childhood vaccination and coverage to the best that they can. We have seen major innovations in outpatient and inpatient care, and we've adapted, and we've actually found some things that work. And I just wanted to point out in lots of countries around the world, the expansion of remote and telehealth care, which is of course bringing healthcare to some populations that did really struggle with access in the past. So that surge of support and need for remote and telehealth has really enabled a more inclusive approach to lots of patients around the world, and hopefully we'll see that really bring in other disease processes and management that can happen remotely. We've seen enormous strengthening of the public health and global health surveillance system. So hopefully our ability to detect a virus like COVID again in the future will be 100% better. Again, maybe I'm optimistic, but a lot better than 100%. But I think we will see the benefits of all of that work on the epidemiological systems in most countries to trigger an alert to concern and investigate, respond. I think unlike we've seen, because of the sheer magnitude and engagement within the COVID-19 pandemic, we've had great international collaboration. And so that's bringing scientists, methodologists, researchers from around the world so that we can benefit from that information. We've seen trials coordinated, I think, for both clinical care interventions, for therapeutics, diagnostics, happen simultaneously in multiple countries, and also encouraging that we could get low and middle income countries also equally engaged in those science and research efforts. So we've got a much more global agenda being driven from clinical trials occurring all over the world. Health system strengthening, as I said, we're going to be better prepared to both detect and respond moving forward. So we take some of those good things. And I just wanted to flag on the last point, which is the global recognition of nurses and midwives and the conditions in which we work and impact on patient safety and care. And I think the good with the bad, we recognize that I wish we didn't have to have a pandemic of this size and nature to bring nurses a little bit more into the forefront and the work that is happening on the front lines of patient care. But I do think, unlike any time previous in history, we've had the spotlight and attention to hopefully address some of the situations around staff ratios, working conditions, retention issues that we know affect our everyday ability to care for patients. I just want to talk a little bit about what I do at WHE. So I work within the clinical management unit, which is a multidisciplinary team of doctors, researchers, epidemiologists, technicians, and we work to hopefully synthesize norms and standards. And that's a critical part of what we do. In many countries, they're unable to pull all of that information that's happening in real time together. They may not have the system, the size or the spectrum of experts that they need. So they really rely on WHO to produce those guidelines on their behalf. So we produce a range of guidelines from clinical management to therapeutic to all kinds of tools that hopefully help influence patient care and drive national agendas for care. We do a lot of work on global webinars. We maintain multiple websites where people can access information. We provide free and available training for health workers. We push as much as we can through social media, and of course are building toolkits, and those are being updated all of the time. For research and innovation, we have a clinical data platform and a number of ongoing clinical trials where we can synthesize real-time information. Just to give you an example, the global COVID-19 clinical data platform has about nearly 600,000 individual patient records from patients all over the world and their COVID experience inside a hospital. And so that allows us to have an idea of how care is evolving in many settings around the world all at the same time. It's a wonderful program, and I think we're really excited that this may be something that we can repurpose and continue to use into the future for ongoing emerging infectious diseases. We look a lot at research protocols around safety and pharmacovigilance for introduction of new drugs. We look at, for example, running a study at the moment around the use of pulse oximetry and oxygen access in low and middle income countries, just to really get a baseline and benchmark, as we recognize that oxygen for a really long time has been not scaled to the right ratios in many parts of the world. So COVID bringing again attention to that oxygen deficit that we see, and allowing these kinds of studies will allow us to further demonstrate what deficits exist in certain countries, and hopefully that gives us better targets to reach in terms of addressing that deficit. We have a number of ongoing clinical and research networks, so that's experts from all over the world who are involved in different kinds of trials, bringing sometimes new innovations in care. It could be new tools, so sometimes we might see new equipment that's being used. So, for example, advanced respiratory equipment, looking to see where that can be best adapted to in the world. And then we look at global deployments. So we have a number of highly experienced experts in international health crises, outbreaks, who can deploy at a country's request to help them surge or respond to ongoing caseloads. And then a lot of country support, which is through WHO, through member states, able to provide governments, WHO country officers, other partners in the country around operational support. So that might look anything from funding to drug access, through to sort of working through problems around oxygen systems, making sure that if we're looking at putting in a PSA plant, that it's the right kind of plant for the right kind of hospital. So just really quite broad, but all focused on those sort of 5 pillars bring us to enhanced patient care. Just wanted to signpost a couple of quick resources. I won't go into them, but we are just at the moment introducing the COVID-19 clinical care pathways. So that stands for confirm, assess, respond, and evaluate. And that's hopefully going to help us just keep framing COVID, no matter where it's sitting, whether it's in a country with a high burden or a low burden. We have patients who will be admitted to hospital or needing care because of COVID. Sometimes we'll find they have COVID and it will be inadvertent that we find that diagnosis, but this allows us to look at that COVID management within whatever system they're in, what other disease or pathology they're experiencing. And I also just there is the Open WHO, where there's free clinical management training supports for nurses, midwives, doctors, health workers, laboratory staff, you name it, we can cover it. Just wanted to last couple of slides, really sorry, lots of words. I just wanted to flag the team in WHO from the Nursing and Midwifery Task Force. The 2 links in blue, Nursing and Midwifery Global will take you to our community of practice, which is a relatively new feature for WHO, but allowing nurses a space to come and engage, ask questions. We have topics, themes, you'll find signposts for webinars, for new publications that are relevant to practice, and really looking to really reach out to as many nurses and midwives across the board, where hopefully, the more we hear from you, the more we're able to tailor supports and services and target educational efforts towards nurses and their real needs. A couple of really key publications there around the global strategy, and a couple of flags on recent article in the Lancet in 2020 around the health workforce. So just wanted to wrap up 2 slides. I get asked a lot around how one might get into international or public health work or humanitarian work, I just wanted to flag a couple of things which I think are fairly cross-cutting for anyone who's worked in this particular arena. Really encourage new to nurses or new to midwifery to really consolidate your foundational skill sets and really look at what kind of work you're really interested in, what you're passionate about. I think we see a real spectrum from highly specialized nurses working in this kind of field against, so they may be a specialist neonatal intensive care nurse, all the way through to what I consider sort of myself, which is a bit of a generalist, working in lots of domains and having trained in public health. So, you have to really look at those two skill sets and sort of feel where you're pulled. Really encourage travel. I know that's a hard thing to say during a pandemic, but travel I think is really, really vital to see a bit of the world, to test yourself working in different countries, different contexts, really understanding a little bit how you operate in those kinds of settings, study. And of course, I think another kind of bonus of the pandemic has been the online capacity that's been created so that you can read and meet and connect with nurses and like-minded people and other healthcare workers around the world doing the same kind of work. And there's just a couple of slides there, I'll leave them at the end, which is around different kinds of education and some short courses that you might find relevant. And three real favorite sources online, which is Relief Web, the Humanitarian Practice Network, and Humanitarian Response, which are really great and informative around international health situations. And that's it from a few wonderful faces of nurses around the world who responded during the pandemic. So thanks very much, Dale.
Vanessa, thank you. I was just thinking as you were talking, I was thinking, oh, we're so lucky to have people like Vanessa here with us today. Such an inspiring story, not just because of your experiences, but everything that you shared with us. And you were saying, another slide in too many words, not at all. I mean, what a pleasure to hear again your story, but also to hear about the support systems that WHO has implemented over the years and is still working on. And you gave so many kind of practical and also personal suggestions to people who might consider, both nurses and midwives that might consider this sort of professional journey. So thank you so much. I have lots of questions for you because time is always short. I've got one. You're clearly passionate about global health and equity of care. And I think that is something that we've been talking about so much around COVID, equity of care, inequalities. And you mentioned in one of your emails, there's still countries waiting for vaccines, et cetera, et cetera. Do you think that when we think about nursing education at both kind of a undergraduate and postgraduate level, do we need to start talking and introducing in the educational curriculum of nurses and midwives global health and equity of care? These are topics that, to me, it sounds like they should be there. They should be included. What's your thoughts on this, Vanessa?
Oh, absolutely. And I think, I came to some of those thoughts quite late in my career. I mean, there's a difference between seeing it and I think being able to understand and process it. And I'm actually halfway through a bioethics master's at the moment, which is really helping me frame a lot of decision-making in healthcare. And of course, we can't ignore that the challenge throughout the course of the pandemic, the political kind of aspects that drive the health agendas. And I think these are pertinent issues that I think we can't leave out of undergraduate education. I think we have to be a global workforce. We have to be aware of what's happening in the neighboring countries or in different parts of the world. And I think, because we have also our clients, our patients are also global, right? So I don't think there's very few of us who don't treat patients from all over the world at different times in their career. So I think this is more than ever important. Couple of, I think, basics around equity and justice and allocation, that can be as local as how do we allocate beds in an ICU. So I think understanding justice and health allocation is really important. Equity, I think understanding the difference and making sure that we understand that we've been here before and we've learned some really hard lessons around trickle down efforts in medicine and healthcare. And I think we no longer can afford to have a trickle down logic. It has to be everyone gets, or actually let's go from from a trickle up effect would be really interesting as well. But yeah, absolutely important. And I think more than ever also most of us do touch on epidemiology and some biostats in our undergrad studies, but I think I didn't pull them out for a number of years, I don't think. And I think now I'm sure people who are training and learning today have got a much more acute sense of interest in epidemiology than I probably did 25 years ago.
Would you have the experience to, Yes. Vanessa, thank you so much. And hopefully let's continue talking about this when we join the group discussion, because I think a lot of what we'll talk about links very much to many of the topics that you've mentioned in your presentation. So thank you very much. Okay, so I believe now we're going to watch a short video that sets the scene about Jhpigo's work and the role of nurses in the clinical area of HIV. Hope that we're going to see the video now. Yeah, it's there. So.
Jerusalema ikhaya lami ilondoloze uhambe nami zungangishilana Jerusalema ikhaya lami ilondoloze uhambe nami zungangishilana dawo yami ayikholana buso wami awukholana ilondoloze zuhambe nami dawo yami ayikholana buso wami awukholana ilondoloze dawo yami ayikholana buso wami awukholana ilondoloze zuhambe nami dawo yami ayikholana buso wami.
So much has changed. I was watching the video and thinking how much things have changed since the mid-80s, 90s, which was kind of the peak of the HIV crisis in some parts of the world, and then later on in Africa. I'm really pleased to welcome now Vusi Ndaba, Senior Field Project Officer for Voluntary Medical and Male Circumcision, and also HIV Prevention and COVID Response Program of Jhpigo in South Africa. Vusi, you, I believe, had extensive experience of working as a nurse in South Africa at the height of the HIV crisis. And I believe that South Africa had at some point one of the highest HIV infection rates in the world. So tell us about those experiences and whether we could use some of those previous learnings from the HIV crisis when now we think about how to respond to the current COVID crisis or indeed future emergencies. So welcome, Vusi. Over to you. Vusi, we can't hear you. You're not on mute, but we can't hear you. Can't hear you. Do you want to try to log out and log in again?
My IT is here.
Oh, there you are. You are.
Oh.
We can hear you. We can hear you.
Thank you so much. I got the IT just as a backup support here.
No problem. Loud and clear now.
And lovely touching base with you guys. And thank you so much. I feel so much privileged to be speaking on behalf of the nurses in the region, particularly in South Africa, regarding our efforts to fight the two pandemics, which is the HIV, AIDS, and the COVID, the COVID-19. Yes, indeed. I've worked tremendously in the HIV, in both the prevention and the care treatment. But you can't talk HIV and AIDS if you don't talk about the UNAIDS 90 goal. And how far are we the goal? Globally, we've managed to come close. We didn't reach the 2020 UN 90 strategies, but we knew that 87% of the people knew their HIV status across the world, and 84% knew the status. 87% of them were already initiated on treatment, and 90% of them, were viral suppressed. And that's just, Vanessa just, spoke about. And now where are we? We are moving to the 95 strategy. And the 95 strategy, it's just, following straight on what they are, where we left with the 90. How does South Africa compares to the rest of the world? How did South Africa fare in the 90 strategy? South Africa managed to achieve 2 of the 90s, and the efforts of the nurses, paid dividends. The first 90, we made 92%, and this was reached in 2018. The second 90, which is, at initiations, we fell short. We just fell onto 75%. And the viral suppression, we are at 92%. And this clearly tells you, if South Africa responds, the world also responds. Globally, we are sitting at 90% of viral suppression. South Africa is sitting at 92%. If South Africa, based on its largest, largest HIV, epidemic, then this would have been a biggest problem with the last 90. And so we all know that, we've got about 7.8 million South Africans living with the disease as we speak today. And this has also pushed the country to be the world's largest ERT program. And, the ERT program has made tremendous work through the hands of nurses for us to be on that, the last 90. So thanks to NIMAT, the nurses, initiated at initiations. This was one of the driving tools to make us face, the problem of, viral suppression initiations. Also, what I can also talk about is before I move into care treatment, my passion is prevention. I've worked for most of my time in prevention, and there are 3 prevention, models or activities that I'm being, currently involved in. First one is the PrEP. South Africa was the first country in Sub-Sahara to fully approve PrEP, as part of the prevention, which is now made available to people at high risk. And who's behind the driving force? It's in the hands of the nurses. So if nurses are there, if people come for PrEP, they know that there's a nurse that's going to dish out PrEP medication for them. I'm not going to dwell a lot on PrEP. I'm going to go to PMTCT, the prevention of mother-to-child transmission. Over the past decade, South Africa has made great progress in reducing mother-to-child transmission. And this was largely due to improvements in choice of antiretroviral medicines and widespread accessibility of the prevention of mother-to-child transmission. And again, the midwife, the South African midwife, has always been there. They made sure that they follow up on our pregnant women and mothers, and make sure that every one of them understand why TMTC is so important. And the rate of mother-to-child transmission, it stood at 1% for the past 5 years, of which in 2011, it was at 3.6%. So currently, as we speak, over 90% of infants that have been exposed, to the HIV virus, they are tested within 6 weeks. And it's because of what's happening in our ANC clinics, what's happening in our delivery rooms, what's happening at postnatal care. So the number of children born with HIV is still relatively high compared to, the monitors that we put ourselves, the indicators that we as the country put ourselves into. But yes, we have made strides, and I think there's still a lot, that we can turn around the wheel. My last prevention aspect will be the voluntary medical male circumcision. We all know that, DMMC is an evidence-based biomedical HIV prevention, which has shown to reduce female-to-male transmission by approximately 60%, and thus, interrupting the HIV transmission cycle. Reaching men, age 15 to 34, not only saves lives, but it's also key to achieving epidemic control. And this epidemic control, it's clearly defined, in PEPFAR, it's clearly defined in UNAIDS, it's clearly defined in almost all the ministries of health. So as the nation, program, the South African DMMC program matures, this bolsters the comprehensive HIV prevention care and treatment strategy for us to achieve, the 90-95 strategy. We are forgetting about the 90-90. We are in the 1995 strategy. So despite the significant, achievements in the VMMC program, the scale up has lagged behind. And now guess who they're gonna ask? Ask the nurses. The nurses has been called to action. So the country's National Department of Health has called up the nurses to scale up the VMMC, which is likely going to be the same way that, the nurses has started with the at initiations, with the NIMAT. So in a nutshell, the prevention continuum in the HIV is very crucial in us, achieving the epidemic control. But remember, I said South Africa has the largest, HIV program. So this is where the care treatment comes in. So we're all aware that South Africa program was launched in 2004. At that time, only 4 million South Africans were infected with the virus. Currently, as we speak, in the last decade, about 3 million more people, almost double that number, are living with the virus. So expanding at eligibility criteria in South Africa faced challenges in reaching the second 90, because we managed to move onto the first 90 and the third 90. Remember, South Africa had serious stumbling blocks. First, it was the issue around the CD4 count, where we were like looking at 200 cells, people that measured less than 200 that were eligible. Then it was raised to 250 in August 2011, and just about in 2015 it was raised to 500. And this did not come without any effort. So South Africa has come far in providing art services, transitioning from HIV care provision by specialists to include GPs. So remember, this was in the hands of the specialists, and now they included the general practitioners. And then a rapid expansion rollout program had to go and has to be initiated. That's when NIMAT came in. The NESH initiated therapy. So what also came in as a crisis was the same-day initiations or universal test and treat antiretroviral therapy, continuum. This actually threw us, into the care of the pandemic as nurses. Now, over 95% of ART initiations are in the hands of the nurses in South Africa. So that clearly tells you why we have met the first 90. And in no time, we'll be meeting the second, we'll be making the second 95 on both the first and the last 90, knowing that we are making progress on the second 90. So what is NIMAT? So the rollout of the nurse-initiated management antiretroviral therapy was implemented in 2010 by the National Department of Health in South Africa in response to the large numbers of people living with HIV who needed treatment. This has enabled us, those people to get treatment with the task shifting from the doctors, like I mentioned earlier on. because we knew there were challenges, there were barriers, and there were enablers. And NIMAT has managed to, to push away all of that. In September 2016, the National Department of Health implemented universal test and treat, like I mentioned before. And this universal test and treat, it actually placed a bit of a, let me just get a cup of, thank you so much. So this universal test and treat, it made sure that PICT, provider-initiated counseling and testing, is in the hands of the nurses. So this is where the nurses, pushed for that first 90. And remember, NIMAT is also in the hands of the nurses. This is where the nurses, pushed us to achieving the third 90. Connecting the dots makes it easy for us as nurses. And just in my few last slides, COVID. You cannot speak HIV and AIDS as a nurse without mentioning COVID. Vanessa has just spoke a lot about COVID, and a lot, is happening around us. So what we had to do as nurses, adapting. Where did we adapt? We provided telehealth. Vanessa mentioned it earlier. Home care. We had to bring care to the people because there were restrictions, there were hard lockdowns. We had to do nursing research. Most of us had to go and see what is that I can do as a nurse that is best for my client or my patient that cannot come see me. Online teaching, learning, including informatics. This is where the nurse took a nosedive and said, there's no way I can be sitting idling here while I've got patients. Virtual symposium and conferences. Most of us, my colleagues around the world, they can attest to it that some of us were not digitally active, before COVID came in. And most of us now can, do virtual meetings. We can invite guests. We can do online workshops. We can do virtual seminars. So, and the impact of COVID on us in PhD nursing. So significant impact of the nursing career with this current, crop that's in here. The nursing students that we are supervising in our complexes, in our facilities. And also in the coming years, nursing needs to shape its profile in such a way that the complexity and skills provided is involved in high quality care at the forefront. So technology will change the way we work. Nursing IT skills will likely become a core requirement of efficient, safe practice, and especially in non-acute settings. So it has made us open our eyes. Lastly, new opportunities. I'm going to skip this slide. Our key recommendations, for as nurses, in the country. Nurses should be leaders in the design of healthcare system, not just in delivery of care. This is what we've learned. Nurses should be considered in every government policy, with senior nurses present at the top of the healthcare systems across organizations and departments. And lastly, countries should adopt a long-term workforce plans, striving for sufficiency in the supply of the healthcare workforce, including nurses. Thank you so much, Joe. I know it was wonderful.
No problem. Again, like I said to Vanessa, I've got lots of questions for you. I'm going to save them for the end. When we have the panel discussion. I've got one in particular that I really want to ask you. I'm just going to say really, really quickly, it's really important to celebrate the success stories that take place in other parts of the world beyond the Western world. And I think that's part of the equity and justice that Vanessa was talking about earlier. So it's so good to hear about what's been happening in South Africa over the past few years with the HIV program and the role of nurses. So let's talk more about that when we go into the panel discussion. Okay, without further ado, I'll jump to the next guest, Gila, all the way from Israel, and I believe you've been involved in your role as a midwife in the COVID response program in Israel. So tell us about that, Gila, your experience and what that meant as well for you as a midwife. Over to you.
First of all, thank you so much for having me. Thank you to the Nursing Now Challenge. It is so exciting to sit with so many nurses and midwives and medical professionals from around the world. And I think that if COVID taught us anything, it's that with collaboration, we can do anything. And moments like this to sit on an international platform are so unique. And I'm just so grateful to be here. So my name is
We're
Dila.
lucky to have you here as well.
I live in Jerusalem. I work in a hospital in Jerusalem. It's called Hadassah. And I had the unique honor to deliver the very first COVID-19 baby in the country. And since then, I was responsible for implementing protocol and running in my hospital, the COVID-19 protocol and implementation, writing things and working with the entire staff. I'm also the head of infectious disease prevention for the labor and delivery. And I only have a few minutes and I could talk for hours. I'm just going to tell you a few points about COVID-19 management, crisis, and mental health. So in March 2020, it was a regular day, and we got a call that a woman had a high suspected COVID. We weren't testing it. This is completely brand new. We had seen the waves of the pandemic coming, and we understood that it was coming towards us. So we were prepared. We had built a COVID ward. We had built a labor and delivery place. We had a protocol in place, and we understood more or less that it was going to be aerosol contact and droplet transmission type of scenario until we understood exactly what we were dealing with. Because I was the head of infectious disease, I was told to run. She was pushing, which is, I'll get to that. A lot of the times we were running because it was in a different place, and get ready to deliver. So I ran, and during the entire delivery, we were laughing because we couldn't believe it. We were like, oh, we're being so exaggerating and this can't be real. And we delivered her beautiful baby. At the time, we didn't understand the impact on the infant, and we disconnected the baby immediately. All she wanted was a picture. I said, what can I do to make this easier for you? And she said, I just need a picture. We took a picture of the baby. She looked at him. We counted the fingers and toes together, and the baby was handed off and put in a separate ward, and the mother went up to the COVID ward. A few hours later, she tested positive. It was the first one. I'm crying. And we realized that we just delivered the very first COVID positive woman in the country. It was overwhelming. She became very ill. Shortly after that, she was completely asymptomatic, but we knew that she'd been in contact with COVID people. She became very ill after that. She wasn't able to see her baby for many weeks. And we, the midwives and the nursing staff, went with her baby. There's something called circumcision. We took her baby to circumcision, videoing it to her the whole time. And the concept of implementing protocol from COVID-19 was a completely unique concept. It's like nothing we've done before. There were no rules. There were no laws. There was nothing to learn from. And as time went on, we understood the importance of adaptation and evidence-based research. As we realized that the WHO came out soon in May, that babies don't need to be separated, we immediately stopped separating mothers and their babies and kept that dyad. The importance of breastfeeding, the breast milk was tested. And we immediately began changing towards the guidelines, but you had to completely stay on top of the research all the time. And that concept of adaptation and implementation and every day getting new research and new evidence-based medicine was an exceptional and an honor to be a part of. The way that we treated women, covered from head to toe with only our eyes showing under extraordinary circumstances, is something that's hard to explain. But I do want to give one call out to a midwife and a nurse. There were no doctors, unless I called a doctor. There were no doctors in this COVID area. It was essentially one-on-one midwifery care, sometimes one-on-two. And the unique part about Israel was that we have every culture and every type of woman. We have Muslims, we have Jews, we have Christians, we have people who have access to more medical care and people who have access to less. And that dynamic is incredibly unique and rich and also challenging. I had one woman who spoke only Arabic in one room, and basic, Arabic is basic, but you speak a language of compassion, with a baby who had died. She was undergoing something called IUFD, a stillbirth. And in the next room, while she was about to deliver, a woman comes in with the head was crowning on her 10th birth, and she had just tested positive. Both of them are alone. Their husbands are at home. Both of them very sick with COVID. Both of their families are at home. And you have two patients who are now in dire need of assistance and management, and it's just you. So I put on gloves and delivered this woman whose head was crowning. Her baby was born not breathing. I resuscitated her baby with my foot holding the door open, asking her questions. What birth is it? Have you bled before? Do you take any medications? And while that's happening, another midwife runs to assist me. I called for help and she ran to assist me. And she reports that the woman in the other room was feeling pressure. So she took over the resuscitation and we stabilized with the pediatrician who arrived with the first baby. And I went in and delivered the baby who had passed away, not related to COVID, the dead baby in the other room, trying to explain to you the dynamics of how this worked. every second, midwives were helping. Every second, we would send texts. We have 2 COVID patients on the way. Who can come? And midwives would respond, I'm coming. We're on our way. You know, how can we help? The concept of collaboration and camaraderie that we felt. So that's going to take me into the mental health. How did we manage? Our hospital was designated as a COVID hospital. So we were specifically given, when a woman was tested positive for COVID, she was brought to us. So we became experts in COVID births. So on the one hand, there's a lot of pride. On the other hand, there's a lot of challenges. So immediately we established mental health groups for the midwives. We had sessions that were run by midwives, and we discussed the mental health aspects and how difficult it was for us in fear. I would come home. I have 4 children. My husband worked also. He's an oncologist. We would come home. We would strip naked in the door. We wouldn't let anyone touch us. We would run into the shower and scrub ourselves down with septal scrub, and then see our children until we understood what we were actually dealing with. That was difficult. But one of the things that helped us get through is gratitude. The concept of gratitude, that everyone around us was okay. And seeing so much suffering and knowing that our children were okay, and my husband and I were okay. So gratitude was crucial. The other thing that really helped me get through was research. Being at the forefront of COVID research, I have now published 3 articles and hopefully publishing another one. I have the honor to be one of the first in the world to show that antibodies go from the mother to the baby in women who are vaccinated with a COVID-19 vaccine. Our research is one of the first in the world to prove these things. That creates a lot of the word in Hebrew is sipuk, a lot of satisfaction for your profession. So getting involved in research, being at the forefront of research and academia really helped me personally with my mental health. And the last thing that I think was that understanding that we're part of a global community. We're not alone. It doesn't matter what our politics are. It doesn't matter what our religion is. It doesn't matter what we believe in. We are all birthing women who need to have the highest standard of care. We're all in this together. And that really helped me on a mental health and on an emotional level to help be with the women on a profound way. I want to finish with this slide. What you see in this beautiful slide is an exceptional midwife named Ruti. This picture was taken by another midwife named Shiri. And next to her is a birthing woman. And this is what our preliminary COVID word looked like in the beginning. And no matter what she's wearing and the physical barriers that separate her from this woman, look at how she's sitting. She's just listening and she's talking to her, and we would hold them and we would hug them and we would be with them in these incredibly challenging times. And I think that one of these things that they show is that it doesn't matter what we're wearing, and it doesn't matter where we are, and it doesn't matter the circumstances. Midwives, we're there for these women with our hearts and our souls and our sweat, blood, and tears. Those things make all the difference when we're in crisis. And the ability to publish that data and to show that despite the fact that these women were incredibly ill and that we midwives were all alone, there were significantly less vacuums, significantly less cesarean sections, significantly less stillbirths, significantly less complications. If that doesn't bring us forward, then I don't know what does in a crisis. So we, the midwives and the nurses, will always continue to run towards the crisis and never from it. It is an honor to be here. Thank you all so much. And we just continue to have only help and good things for the rest of forever. Thank you.
Gila, your enthusiasm is absolutely infectious, I have to say. And thank you so much for sharing your story with so much passion and honesty. It's what really transpires when you talk. So what a privilege to have somebody like you here with us. And I've got
I could talk for hours. So thank you so much.
I'm sure that most of us would hear you for hours. You know, I definitely would. So what an absolute pleasure. What an example of, you know, I wrote adaptation, flexibility, and above all, humanity, which I think it's extraordinary. So simple, but so important, like you said. So thank you so much for sharing your story. Lots of questions. Let's hope that we all have time to get together and talk about this in the panel discussion. So thank you, Gila. And I'll move quickly to our next guest, Jennifer Breeds. Sexual and gender-based violence affects millions of women and girls all over the world, irrespective, like Gila just mentioned now, social status, ethnicity, of age. Those things really don't matter. And we know that so many women and girls are victims of gender-based violence. It can in itself be described as a health crisis, considering the impact it has on the physical and mental well-being of women. But it's also associated with many other forms of crisis, some of which we have debated on previous webinars. So really keen to hear from you, Jennifer, about your experience and perspectives on this topic, and what is the role of nurses and midwives in addressing this huge problem. So welcome, Jennifer.
Thank you so much, and thank you to the other panelists. The enthusiasm was just palpable. I feel I would get along with this group very, very easily. I do have a slide deck I'm hoping could be brought up and put into presentation mode there. Perfect. So thank you again. My name is Jen Breeds. I'm a technical advisor at JPIGO and a very proud nurse of almost 15 years come July. I hit my 15-year mark. And today I'll be talking about this topic of nurses and midwives leading the charge to respond to what's truly an epidemic of gender-based violence with a focus in humanitarian crises. Next slide, please. So just by way of background and as a little bit more of an introduction, for most of my career, I've provided direct nursing care for survivors of sexual and intimate partner violence here in the US. In 2014, I actually moved to Northern Iraq, and I was working for an international NGO and responsible for implementing programming for women's protection and empowerment services at a refugee camp of over 100,000 Syrian refugees. And now working in the role as an advisor at a global health NGO, but based at headquarters, I have this opportunity to be part of incredible teams all around the world that are working hand in hand with ministries to strengthen health systems to be able to actually deliver the high quality care that we as nurses know survivors need and deserve. And this image is actually a picture from a first-person opinion piece I wrote in celebration of 2020, the year of the nurse and the midwife, in which I shared an experience when I was told that because I was, quote unquote, just a nurse, I would not be able to do the work that I do today. And I'll let you all read the full article. I won't entirely spoil the ending. We'll make sure the link is shared. But in that moment, I knew that proving the statement wrong and showing the world exactly why nurses and midwives do not just belong in these spaces. We're not just at the front lines of care and innovation for survivors. We are the front line. And our voices belong in those leadership spaces to advocate for what we know needs to happen for survivors based on what we are hearing and the trusting relationships we establish so that we can support the future direction, especially in fragile settings of how health systems respond and all of the work that we know needs to happen in this space in particular, which is highly stigmatized and very challenging and sensitive. And so I hope to make that case to you all over these next 8 minutes. Next slide. So what is gender-based violence? Well, gender-based violence is, it's really an umbrella term for many forms of violence that are rooted in deep inequities because of gender and that cause physical, sexual, psychological, emotional, or even economic harm. And some common forms are listed here. I'm not going to read them all off to you, but I specifically put what we call IPV, or intimate partner violence, first. And that's because it's been really well documented that this is by far the most common type of gender-based violence that impacts women and girls in humanitarian crises. Most people don't know that. Sometimes there's a connotation, that it's always a stranger. But in fact, some studies actually have documented rates of up to 3 out of 4 women that are in partnerships experiencing IPV in conflict areas. It's extraordinarily high. In terms of sexual violence, women and girls also certainly experience sexual violence in humanitarian settings. The global estimates there suggest perhaps 1 in 5 refugee and displaced women having reports of incidents of sexual violence. And there are other forms of gender-based violence while receiving less attention than sexual violence and IPV that certainly are also impacted by conditions in humanitarian settings. So for example, We know and unfortunately see cases quite commonly in which girls may be married off at a young age when families are no longer able to provide for their basic needs during a conflict or a natural disaster. And I do want to point out that, based on the evidence, the majority of victims of sexual and gender-based violence are women, and the majority of perpetrators are men. But that is not to say that men cannot also experience sexual and gender-based violence. Certainly that is possible, and certainly men survivors are just as much in need of our response and our support. Next slide. This is a picture of Domise, the camp where I was working. And I want to talk about some of the drivers we see for gender-based violence in emergency settings. So we know increased poverty, lack of livelihoods, family separation, and disruption of existing services are huge drivers. But other factors are increased substance abuse, alcohol consumption, and also related to gender roles, and which is really the root cause of gender-based violence is harmful gender norms and practices. And we saw and see in the evidence that sometimes it's reported that the inability of men to be able to fulfill what they see as their masculine roles, especially in these settings where there is no work, everything is disrupted, that's been documenting as a potential driver of especially intimate partner violence in humanitarian settings. And I think we all know, or at least could certainly understand, how COVID and movement restrictions certainly increases the risk for gender-based violence and intimate partner violence everywhere. And we've seen global trends increasing, not just in humanitarian settings, but certainly in those spaces as well. Next slide. And just a little bit more about GBV in emergencies to set this context. It's sometimes referred to as a silent or private epidemic. But we know, and we have global guidance that tells us that all humanitarian personnel and nurses and midwives, chief among them, we should not assume that just because GBV, we do not see reports or do not hear cases in our logbooks, that does not mean it's not happening. In fact, we are to absolutely assume it is occurring and that it's a life-threatening issue that requires urgent action to respond to and to prevent. Next slide. And so the reason this is really, it's an important issue from a human rights space, but also for health. I mean, this is, as healthcare providers, this is our responsibility to pay attention to and to address in our work. We know there are grave effects of GBV on mental health, sexual reproductive health, including even risk for severe injury and death. We know for pregnant women and newborns, there's an increased likelihood for low birth weight babies. We also know that GBV and HIV are mutually reinforcing epidemics. GBV is both a risk factor for HIV infection, as well as a consequence of being infected with HIV. And so women who experience violence in intimate partnerships face a 1.5 times higher rate of acquiring HIV, according to global estimates. Next slide. So how are nurses and midwives stepping up to address this, to face this issue head on, to support the needs of survivors? Next slide. Well, nurses and midwives, we know that we may be the only person who a survivor might interact with in a healthcare setting, especially in humanitarian settings. And that sometimes we're the only person that a survivor can turn to for support, or that could build and has built a trusted relationship with over time. Part of the nurse's role in responding to GBV includes what we do best, which is talking and listening to our patients and providing that empathetic communication to be able to hear their concerns, inquire about needs, validate experiences, and then work together with the survivor to develop or enhance a safety plan and help them identify the resources that they feel ready or interested to access. And that's what the LIVES model listed here, which is WHO's model for best practices in first line response. That is what nurses do. This is who we are. This is what we're trained for. And this is what we do every day. And there's specific ways that we can do this in trauma-informed ways to meet the needs of GBV survivors. Next slide. And in addition to our psychosocial counseling, nurses and midwives were well positioned to also provide critical post-assault clinical care and treatment with the right training. And so we have global guidance and training tools, which I'll share the links to at the end of. These are the steps of what we do in the clinical management of rape. And it's absolutely appropriate for trained nurses and midwives to be providing this care and offering this support. And this is part of what our skill set and our preparation entails us to do. And we can meet the need, especially when we know that our physician colleagues and others who aren't on site or available in many of these places, we can and do meet that gap and fill that need and make sure survivors get the care they need clinically and also psychosocial. Next slide. So I did want to mention some of the things that, it's important to distinguish between what nurses and midwives should do in terms of their role in GBV response versus what we're not responsible for. Nurses and midwives absolutely should provide competent, compassionate, and confidential assessment, care, treatment, and referral to all survivors. But it is not our responsibility to solve violence for a survivor or to determine the legal aspects of violence or determining whether someone is telling a truth or even necessarily having to mediate relationship problems between a couple in that moment, or certainly not forcing anyone to take action they're not ready for. Even if we ourselves believe it's in their best interest, we are working at a survivor's pace and meeting them where they're at, just like we do with all of our patients every day, and really understanding and practicing that essence of what patient-centered care means. It's walking with our clients and meeting them where they're at. Next slide. And so why is this type of care a little bit different from what we do in most of our healthcare roles? Well, certainly in this situation, again, it's not our job to diagnose whether or not violence happened. It's our job to listen to a survivor and to support them and to support the person that has come to speak with us and that we are charged with supporting and meeting their needs and guiding them through a difficult time, right? So patient safety also in these situations may be an ongoing concern, not just because they're in a crisis setting, but also because within that crisis setting, there is a crisis acutely within their family or in that camp. And so safety planning is an ongoing concern that we are as nurses constantly supporting and guiding. And that's really a strong role that we can play. We also can support multidisciplinary referrals. GBV response is not just within the health sector. There's certain other legal protection, sectors that are sometimes involved in addition to the health sector, and certainly, social workers or psychosocial services. We are often interplaying with a wide range of players. And I think these last 2 points is, again, our job is to bring power back to our clients who have lost a lot of power and to give them back that sense of control to make their own decisions for what is best for them and to help them sort that during a really difficult time. And because of that, it can be very heavy. And I think that we all have experienced burnout and heard the reports of really difficult, challenging 2 years more of COVID. But also, caring for survivors who also have COVID or who in these situations or who are in a crisis setting can also take its toll on our mental health, and self-care and care for the caregivers is really important, crucial at the center of what we also need to pay attention to when we're in this space. Next slide, and I'm wrapping up here. So one of the things I just wanted to leave us with is an opportunity for nursing and midwifery leadership in GBV. And what I really see is we have an opportunity not just to be doing response work, but also prevention. And this is an area where I would love to see more discussion. I would love to see more action, and really nurse leadership and voices stepping up to really work on those social determinants of health, that community-based norms work and liaising with other partners who are supporting communities to become more resilient, and really applying a community health lens and doing more gender norms transformation work, and also empowerment work to support women and girls, particularly to build their own resilience and capacities as well. And our next slide, thank you, one more slide. So I did want to leave as well a few training resources that are developed and available open source at these links for nurses and midwives. JPIGO had the opportunity to partner with the Interagency Working Group on Reproductive Health and Crises in the revision and re-release of these new training modules that are specifically designed for the clinical management of sexual violence survivors in crisis settings. And the final slide, these are all training materials that have been updated with the latest global guidance and technical tools, including from the WHO and IWAG on reproductive health in humanitarian settings. And so, you know, there's a lot of ways to get involved in this space to learn more. There's a lot of agencies doing really excellent work. Final slide. And so I just want to say thank you for giving me a chance to talk about a space that I'm certainly quite passionate about, but also as a reminder that this is a space where we all, anyone who takes care of a patient, we very well could be taking care of a survivor without knowing it. And so just having this be on our radar and recognizing that even the smallest action or listening session can make all the difference for a survivor to feel heard and seen. And really it's why we do what we do, and it's part of the beauty of why nurses and midwives are so excellent at providing this care and should be at the front lines.
Jen, thank you so much. Here's another inspiring story that we would like to find out so much more about. So thank you for sharing your story. I have lots of questions for you. Time is not on our side, unfortunately, but what I'll do is I'll bring the whole panel together now, and I'll use this opportunity maybe to ask individual questions to each one of you. Is that okay? So usually in the final panel discussion, we bring people together and we try to find out what have we learned from the past and current experiences, and how can we better support nurses and midwives working in particular crises. And today, obviously, we're talking about health crisis. So under this kind of umbrella question, I'll just ask you individual questions about the various different things that you talked about. Going back to you, Jen, you know, it's difficult to know what the data tells us, I suppose, about gender-based violence. We now seem to, at least here in Europe, we seem to talk more about it. But do we have any sense of how things have progressed over the past few decades? And above all, do you think that you mentioned that we all need to be, as nurses and midwives, aware of the people that we see as we care for them? Do you think that we need to have, like I've asked Vanessa earlier on, more, we need to see more about this topic on the educational curriculum of nurses and midwives, both kind of undergraduate and postgraduate? Do you think that addressing these issues would be important? So over to you.
Yes, thank you. I do agree that this wasn't a part of certainly my training, my pre-service education, you know, over 15 years ago, but it is something that more and more we're paying attention to, certainly in our in-service training work, and certainly in JPIGO programs. This is something we program in a lot of our work, especially our work on HIV and with adolescent girls and young women and talking about these things. But it certainly should be integrated from the start and reinforced over and over again. It's sensitive, and I do understand that without the right training and support to do it, it can feel very intimidating to walk in and raise these questions. And we hear that a lot as one of the reasons why nurses don't feel comfortable inquiring or asking, right? But that's us creating a barrier even to survivors accessing care. In terms of data, it's interesting when we see, so there have been more and more, there's more and more attention paid to tracking and trying to get a better sense of monitoring. But again, we know that for a lot of good reasons, sometimes survivors do not come forward, and that's a calculated personal choice based on what they know of their own situations. And so for that reason, when we see data of it like showing an incidence increase, it's actually a good thing, because it means that people finally are coming forward. It means that those barriers and that stigma is being lifted, and they're at least seeing a facility as a place where they can receive the support that is trusted and where they can have their needs met. When I read a facility report and they're telling me there's no cases or there's only been a handful, I'm very worried about the quality of what's happening there and the training, and my radar goes off. So it's actually almost the opposite. You have to think a little bit differently when we're looking at how we use data to inform our decision making.
Thank you, Jen. That makes a lot of sense. The other thing that I wanted to ask kind of relates to this as well. We heard, from all of you, absolutely outstanding examples of how nurses and midwives are so important. And I think it was you, Jen, as well, that said, we're not on the front line, we are the front line during health crises. And for example, you, Vusi, you talked about the incredible role that nurses had throughout the HIV crisis in South Africa. My question to all of you is, do you think that governments, local authorities, even employers recognize this role? And if yes, how is it reflected in terms of our practice? And if not, what's missing? What needs to happen? Because often, we hear in these webinars talking among nurses and midwives, and it's almost, how do we actually bring this conversation beyond our remit? So do you see that role being recognized? And if not, what else can we do and should we do to promote this role and bring us really to the forefront of this debate? To any of you, maybe Pandora, you've been kind of following us on these webinars and been very much part of the webinars. What are your thoughts on this?
My thoughts are always, when I look at any of the health crises that we as nurses and midwives are responding to, is that we have to get out of our spaces in more creative ways to reach other kinds of audiences, who will help to carry the message forward, that grassroots movement. When you go back to the video that was being played, under it you heard the Jerusalem, right? The Jerusalem dance challenge. You're all nodding. What did Jerusalem show us? Anglophone Africa, it came out, HIV is still going on, all these other things are still happening. It caught the world, didn't it? In COVID, it was a point of hope. It spiraled. You saw lots of healthcare crisis workers, firemen. Think about all the hospitals all over the world. If you haven't seen it, Google it. Look at the healthcare workers. It's caught on. If that could go viral by reaching new audiences in a creative way that touches your heart, not just your head, why can't we do that for any of these crises that we're in? Bring your full self. And let's take up a new kind of a challenge to spread the message.
Thank you, Pandora. Vanessa, on that note as well, any thoughts from you with all the experience that you have of working at so many different countries with so many different people? How can we kind of bring the conversation beyond this circle, drag other people and get the attention that I think we all deserve?
I would say that we've if we can't make it now, I'm not sure we can. I think we're at the crescendo really of a moment to harness the political support for nurses and midwives in terms of creating workspaces that are in conditions that are safe, you know, that we can balance, you know, working, home lives, ongoing education, provide the kind of care that I think we all trained to want to give, and not feeling that compromise. So I think we have to use and leverage the pandemic, this global moment, when we can really look at the role that nurses and midwives have played in care all over the world. And when I say care, I mean all aspects. I mean from you know, being supports in our neighborhoods all the way through to our professional capacity. So this is the crystallizing moment. I think we need more voices. We need more advocacy. We need to actually find our voices, because I think for so very long our professions have done the work in the dark. We have done it no matter what. We put our patients and their families first always. And I don't want to compromise on that, but I think we have to find our voices at the same time to continue to ensure that we create a working environment where young nurses and midwives want to work, and we can continue to see our professions thrive. Thanks.
Thank you, Vanessa. Gila and Vuzi, I would also like to hear some final thoughts from you. Maybe Gila, you go first. Anything that you want to share with us?
As usual, I have so much to say, but I'll make it quick. My master's was on the impact of the Me Too movement on CNMs and OBGYNs. And as a response to Jennifer, we 100% are seeing significant impact of the Me Too movement on the questionnaires. Doctors, the OBGYNs and the CNMs responded that they ask every woman, it was statistically significant since the Me Too movement, asking women if they have had any sexual harassment, trauma, or assault or rape in their past before performing a vaginal exam. There's more chaperones involved. So we are seeing a trend towards change. This was again in Israel, but we are hopefully that will continue at a global level of research. But there is definitely a trend towards global change. I believe in the awareness of gender-based violence also within the healthcare community, not just from patients to doctors, but also among healthcare professionals, women coming for asylum, us being more aware of genital mutilation and all the things that are included in that. So I do think there's a positive trend thanks to efforts like Jennifer's suggesting and doing and working hard on, and Me Too movement and just raising awareness. I think that we are on a precipice. I believe that midwives and nurses are standing on a precipice. And I think that's thanks to COVID-19. For every darkness, there is light. And COVID-19 has created a lot of light with regards to awareness of our roles. We are not, as was said earlier, on one of the forefront. We are the first people to greet and meet and treat these patients. And there is nobody there but us. And if we're going to create change, only we can do it. And these conversations are the beginning. I don't think we're there yet. I think the first thing that needs to happen, there's trickle down, trickle up. The first thing that needs to happen is we need midwives and nurses in government. There should be no governmental body without the voice of a midwife and the voice of a nurse. If you are making any policy regarding women's health, a midwife and a nurse must be there. Once we have international policy on the definition of a certified nurse midwife or midwife, I know there's so many, or a certified professional midwife and a nurse, and these are global policies and global definitions, I think that will begin to make a lot of change. And from up, starting from the bottom, we need to be involved in research and educating. We need to be in the medical schools. We need to be in the nursing schools. We need to do the research. We need to be at the forefront of research. And once we have our voices on an academic and professional level, I think that will start to create a lot of change. We're getting there, and there's a lot of hope. I'm incredibly hopeful.
Thank you, Gila. So many ideas and good thoughts there. That will make me think of the last thing that I'm going to say. So just hold on to that thought. Vuzi, over to you. Some final thoughts from you as well.
Thank you. Thank you so much, John. And I think, my colleagues have said a mouthful. My take is nothing about the nurses without the nurses. And that's basically the underlying tone. We need to be at the forefront of policy. As much as, when crisis hits, the nurses are called to the front. Policy should be.
I think we've lost Vuzi. Vuzi? Can you hear us? I think we might have lost Vuzi, unfortunately. Can you guys hear me? You can hear me? Okay, okay, so we lost Lizzie. Okay, unfortunately, time is, like I keep on saying, not on our side, which is always something that makes me really sad. I just wish that these conversations could go on forever, but I know that we're all in different parts of the world, and lots of the people that are watching us are also in various different corners of the globe. We're absolutely delighted with the responses that we had to.
I lost you guys there. I don't know if I'm back.
Really?
Yes, that was my final thoughts, Joao. I think I'm fine. Yes.
Okay.
So I would say the policy should be, a nurse-driven policy, including the male voices in the profession. So government should listen to us. Politicians should listen to us. We'll design the policy as nurses. Thank you so much.
Thank you. No, thank you, Vuzi. I was just saying, Vuzi, as we couldn't hear you, that it's been, we had an incredible response to the various webinars that we did under this kind of umbrella term of nursing and midwifery in crisis. And we really want to keep the conversation going. And this brings me back to what you were saying now, Gila. You're just throwing so many different good ideas. Over the coming weeks and months, we will be holding different workshops about many of the topics and themes that we've touched in this series. So we really want people to send your ideas. If you think that there are other topics that we should be discussing under this umbrella term of nursing and midwifery in crisis, and we want to ask people to look out for social media. That is Nursing Now Challenges Facebook and Instagram pages, as we will be most certainly keeping you all posted on how we move along. And we really look forward to meeting everyone again. So the plan at the moment is to have workshops, invite lots of the panelists that we had the pleasure to meet, like yourselves, to these workshops, and continue this conversation so that we can think of many of the ideas that have been discussed today. How can we put them into practice? Is that something that we as a connected community can do to put some of these ideas into practice? And with this, I'm going to have to say goodbye to everyone. Thank every single one of you in the panel to join us today. Thank you as well for everybody that watched us at home or in their workplaces. And we really look forward to meeting and seeing everyone again and to continue this conversation. So thanks a lot. Bye-bye.